are you online?
Yes, I'm here.
I'm sorry. Can you pronounce your name, because your name is I'm afraid to introduce you with the wrong pronunciation.
Understood. It's not easy. You can pronounce like a Burapa or Burapa. Burapa is right.
Is the first name, right?
It's the first name, like my
and
surname.
The last name is Pusahama,
which is much more difficult.
Pusahama. Okay, and you're from the Konkan University.
Konkan.
Okay.
Konkan.
Great. Konkan University.
Yes.
Dear Chairperson, time is up. You may start.
Okay. So good afternoon, and please welcome to APSC Cloud Forum of Cardiovascular Disease series. Today's subject is updated diagnosis, classification, and treatment of pulmonary hypertension. Different etiology, different approach. So the pulmonary hypertension is a complex pathophysiologic disorder involving multiple etiologies in pulmonary hemodynamic deterioration. So in this specific session, we will explore systematically the classification of pulmonary hypertension based on etiologies, therapeutic approaches for pulmonary hypertension of various pathophysiologies, pulmonary artery hypertension in adult congenital heart disease, pulmonary artery hypertension in adult congenital heart disease, chronic thrombo-embolic pulmonary hypertension, and the destinational lung transplantation for unresponsive or terminal pulmonary hypertension. So today, the co-chairperson first is myself. I am Dr. Mungu Ulbatar. I'm from Mongolia. I'm the clinical professor and chief of cardiac rhythmology center at the National Cardiovascular Center, and I'm located in Ulaanbaatar, Mongolia. And I'm very pleased to co-chair this session with Dr. Yang Hong Lin Austin. He is the clinical professor of the Department of Internal Medicine of National Taiwan University College of Medicine. He is the director of Cardiac Intensive Care Unit of Cardiovascular Center, National Taiwan University Hospital. He is the president of Taiwan Society of Hypertension and the president of Taiwan Society of Aldosteronism. So thank you very much for your collaboration. And we have some housekeeping information before we start. So the content of this webinar is copyrighted by Asia Pacific Society of Cardiology, and it should not be distributed without any prior permission from the Asia Pacific Society of Cardiology. And the views and opinions expressed in this webinar are those of the faculty members and do not necessarily represent those of the Asia Pacific Society of Cardiology. And the live streaming content of this webinar will be made available via Asia Pacific Society of Cardiology Cloud, APSC Facebook and YouTube pages. So please welcome to today's session, and let's get started with the first presenter. So do you have anything to say, our co-chairperson, Dr. Lin?
Thank you. It's my great opportunity to co-chair this section. I think pulmonary hypertension is a very challenging clinical situation, and we have faced many patients about this trouble disease. So I'm glad to have the chance to collaborate with such great speaker, and we will share our experience about the treating these patients. Thank you.
Okay, thank you. Thank you. So let's start with the first speaker. The first speaker is Dr. Batirton Nimsurung. He is from Mongolia. He is the cardiologist from the cardiology department of Mongolia, Japan Teaching Hospital of the National University of Medical Sciences, and he is the faculty member of cardiology department of School of Medicine of the National University of Medical Science. So he will be speaking today about the updated diagnosis and classification of pulmonary hypertension for each group 1, 2, 3, 4, 5. So microphone is to you. Thank you.
Hey, thank you, professors. And thank you for selecting me this webinar. And then I'm gonna start with my slides. Is it full slide?
Yes, please proceed.
Okay, thank you, sir. So as you mentioned, the chairman and professor mentioned about the pulmonary hypertension, it is challenging in the clinic. So even in our country, it is like at least minimum attention to the, of the cardiology practice. So it is very important to also to us to improve this knowledge and practice to the next and colleagues. So I'm happy to speak out this session. Okay, so from the last years, so the guidelines of the pulmonary hypertension is not like long reviewed, because before the 2020 guideline, there was 2015 guideline on the European Society of Cardiology. But the 2018, there is World Society of World Symposium of Pulmonary Hypertension. They have some also new guideline. So about the Mongolian, we follow the European guideline, and also the world also follows. So on this new guideline, there's many changes and many revised recommendations for this one, like 80 new recommendation on this guideline, and about like 44 revised recommendation on this one. So there is like huge changes on the last guideline. So I'm gonna introduce only the definition and then also the diagnosis of the pulmonary hypertension. So the guidelines through over the last like 3 decades on the pulmonary hypertension is following like this graphic. So like first definition of this the pulmonary hypertension is over like 1973. So this year's like definition is not the hugely changed, because of there's like not the wide availability of the right heart catheterization. So it is like only based on the echocardiogram and then some limited data. But right now we have big wide availability of the right heart catheterization and then big clinical data. So the last guideline of the definition is outdated on the pulmonary hypertension. For example, previously the pulmonary hypertension at rest is mean pulmonary artery pressure. Hypertension is about over 25 is the hypertension. So, but the new updated guideline is over 20 is new updated definition of the pulmonary hypertension. So also there is also big changes on the exercise pulmonary hypertension, because previously there is over 30 is at the exercise is the pulmonary hypertension exercise definition, but the new one is like I'm gonna explain you later. So why is the new cutoff value is introduced at the latest guideline? So it is, of course, based on the clinical data and also clinical trials. So on this example, 2016 from the circulation, so they gone through the lot of the veterans and doing the right heart catheterization during hospitalization. So they follow up this like 20,000 patients, almost like 3 years. So this graphic said about this borderline pulmonary hypertension is over 20. Is like a hazard ratio is increased than the reference range. Also, the hospitalization rate is also like worse in the over 20 group. So that's why the new guideline proposed that the over 20 is pulmonary hypertension risk at the people. So they increase the future risk of the death or future increase of the hospitalization rate. So that's why the new hypertension definition is introduced at this guideline. So on the exercise hypertension, on this second clinical meta-analysis review of the pulmonary hypertension is also true for the like mild hypertension. So it is like over 20 is like worse than the reference group. So that's why all of these studies, all of these clinical trials suggest over 20 is the new definition for the hypertension by the right heart catheterization, of course. So how about the exercise, the pulmonary hypertension? Also, historically, there's over 30s at the exercise is the pulmonary hypertension, but there's very limited data of that right heart catheterization through that. So in normal people also at the exercise, normal people vascular pressure is also increasing through this graphic. Especially we can see this control group is all over the 30 under the exercise. So this many clinical reviews and many clinical also studies suggest that only just 30 is not enough to detect the exercise pulmonary hypertension. So new guidelines suggest that sloping like over 3 millimeter mercury per liter per minute at the exercise sloping is the new definition for the exercise pulmonary hypertension. So that's why there's like 2 huge changes on the definition. Okay, how about the classification of the pulmonary hypertension? So it is like mostly unchanged, the last guidelines. We all know group 1 to group 5. So group 1 is like true pulmonary arterial hypertension. So others we already know. So how about the changes? So on the last 2022 ESC guidelines. So there is two type of the changes under the idiopathic pulmonary arterial hypertension. So that is, we already know the vasoreactivity testing. So that's based on the vasoreactivity testing, like non-respondent and acute responders. So also there is like persistent pulmonary hypertension of the newborn, and also the last two is also added to the group 1. So it is very important of the vasoreactivity testing under the idiopathic. So let's see this, the recommendation, the guideline is recommending about the vasoreactivity testing. So it is like one class, 1B level of the, for the vasoreactivity testing for the group 1 patient. Even it is like responding to the vasoreactivity substance, like isoprostol, thiopurstol, inhaled nitric oxide. But on this guideline, the adenosine for the vasoreactivity testing is not recommended anymore. So we will not use anymore adenosine for the vasoreactivity testing because of the many side effects for the adenosine. Okay, so how about group 2? So I think we are all cardiologists, and we are facing a lot of patients with the heart disease. So under this guideline, like classification is not changed, but there is two types of the pulmonary hypertension related with the left heart disease. So, but that's related, that's based on the pulmonary vasculature pressure. So if the patient with the left heart disease with the mean pulmonary artery pressure is over 20, so it must be evaluated by the pulmonary vascular pressure. If it's under 2 Woods, like 2 Wood units, it's like characterized by the isolated post-capillary pulmonary hypertension. If it's over 2 Woods, it's like combined post and pre-capillary pulmonary hypertension. So if it's over 5, that's severe pre-capillary component. It's also the treatment is very special to that kind of severe patient. So we all know the heart failure with preserved ejection fraction and reduced ejection fraction. So even some patient with preserved ejection fraction has a worse prognosis than the reduced heart failure. So that is because there is in the pulmonary vascular system, there is resistance is increasing in the pulmonary vasculature. So it is like telling us this kind of patient has a worse prognosis than the no pulmonary hypertension patient. So that's why it is very important to know that kind of patient, even it's preserved heart failure patient. So the group 3 with the related with lung disease, so the it is also like very similar, but over 5 Wood is the new updated definition of the severe pulmonary hypertension on this patient. So previously, severe hypertension is over 35, but the mean pulmonary pressure artery is not exactly tell the patient prognosis or patient the treatment. So the guidelines said using the pulmonary vasculature pressure is very important for determining this patient is severe or not severe. Okay, how about the diagnosis for the pulmonary hypertension? So the guideline the new guideline said it is very simple and simple algorithm to detect the pulmonary hypertension from the primary care to the pulmonary special centers. So the diagnosis could be like step 1 for the suspicion for the pulmonary hypertension, step 2 for the detection, step 3 must be the confirmation for the pulmonary hypertension. So the on the suspicion for the pulmonary hypertension, there's like this kind of patient is going to the primary care center at the first, like, so this kind of symptoms and the common and rare symptoms is facing the primary care. So, but at the primary care, these symptoms are very general, not the specific for the pulmonary hypertension. So that's why many patients with pulmonary hypertension not easily detected by the at the first. So there is like algorithm for the diagnosis. So on the detection, we use echocardiography. So on the echocardiograph, there is also like the simple and probability algorithm for the pulmonary hypertension. So if the tricuspid peak velocity is under 2.5, 2.8, that is like low probability. But if there's any other sign of the pulmonary hypertension sign on the echo, that must be going to the next probability. So guidelines said this kind of algorithm is easy to follow up, easy to use this kind of graphic. So like over 2.4 for the TRV, so that is like very high probability of the tricuspid pulmonary hypertension. That kind of patient must be go through the center for the cardiology, and then must be future intervention by the right heart catheterization. So how about other sign of the pulmonary hypertension? So like we already know all that kind of the features of the echocardiograph. So if patient has the increase of the tricuspid regurgitation, so we must use other sign of this kind of echocardiograph signs, so guideline sign. So from the guideline for the diagnostic strategies, so we have to use abnormal TRV. Also, we have to use other sign of the echocardiographic sign. So that is like class 1 recommendation from the guideline. So according to the TRV, so we also divide the patient by the probability and then send them to the follow-up or send them to the next like pulmonary center or cardiology center. Okay, so the last step for the diagnosis is the confirmation. So the right heart catheterization is the gold standard for the pulmonary hypertension diagnosis. So which kind of patient goes to the right heart catheterization is like guideline recommended that when the intermediate or high probability patient must go to the pulmonary like center, hypertension center, or presence of the other risk factors for the pulmonary arterial hypertension or history from the pulmonary embolic patient must be evaluated by the right heart catheterization. So that's the last step for the diagnosis. So guideline also recommended that the right heart catheterization is not just like the pulmonary arterial wedge pressure. It is also must be during the catheterization take all of these parameters during the right heart catheterization. So from this value, we have to calculate other parameters. So we using these parameters to treat the patient like based on this lot of right heart catheterization dynamic. So the diagnosis of the pulmonary hypertension algorithm is like this. So we're gonna use this other kind of the EKG, like pro-BNP and oxygen saturation is our early sign of this disease, and we have to evaluate by the underlying disease by following like chest X-ray, chest CT, or echocardiography. Okay, so the that is the last slide, and then thank you for the attention. So it is huge for me for the participating in this webinar. So thank you for that.
So thank you very much for briefly summarizing the different groups of the hypertension and possible diagnostic approaches. And just before we have some shortage of time, but in terms of this daily clinical practice among these different groups of hypertension, if you suspect, for example, pulmonary hypertension, which group of hypertension would you have to say look for as primary, have to say, clinical practice, or which one is more prevalent and which is more occurring to your practice?
Mm-hmm. Okay, thank you for the question. So according to the data from the guidelines, so there is the group 2, like the left heart disease patient is a lot common. And also in my practice, also there is like congenital heart disease patient is also common in Mongolia. Also the like rheumatic patient, like rheumatic heart disease patient is very common in Mongolia with the pulmonary hypertension. So that is our concern in our daily practice.
Okay, thank you very much.
Thank you for your wonderful talk. And I want to ask, in Mongolia, what is the obstacle for you to screen or diagnosis of pulmonary hypertension?
I think we have the cardiology center for the Mongolia in Ulaanbaatar. So, but that's the only one center, and that center is also doing the cardiothoracic surgery. So I think the obstacle is if we suggest the pulmonary hypertension and patient must be like under right heart catheterization, so we have to patient go to the only one center. So that is like maybe obstacle for me. And also the research and then training is also crucial for the diagnosis for the pulmonary hypertension.
Also, I think the screen is very important because we have to be aware of this disease, because always in all over the world, especially in the resources is not so full country, we have to very with a high alertness to detect the patient and to know this patient, because this disease is only you think about it, you will see it. So always this is not so common disease, so you have to put a very high alertness and a high suspicious for every probable patient to detect the disease.
Yes. Thank you for the feedback.
Yeah, actually, I think I do agree with Professor Lin that among the doctors, there are not many, I mean, the awareness, general awareness and looking for pulmonary hypertension and its causes is quite not at the sufficient level. And especially in Mongolia, we have a long distance and many doctors function in very isolated locations where sometimes even echo is difficult to search. So And even today's webinar is very crucial for us for the training and to create awareness among the doctors to search for pulmonary hypertension and its causes. So it is a very important webinar, I think.
Yes, even in Taiwan, even we are in the small island, but we still need to spread the common sense of pulmonary hypertension to the primary care doctors, because most of the patients see the primary care doctors for the usual disease. So only the medical center is for the referral, especially the PH center. So how to detect and how to screen is very, very important to treat pulmonary hypertension patients. Yeah, and maybe we can talk about the experience from every country in the end section of QA. Yeah. So
thank you very much, Dr. Butterton, and microphone is to you, Professor Lin.
Yes. Okay. After you diagnosis pulmonary hypertension patients, and the next challenge is how to treat him or she, how to do the risk stratification, and how to do the medical treatment or other treatment, especially medical treatment for group 1 pulmonary hypertension. How to do it, monotherapy, combination, how to combination initially or sequentially. So it's very important topic, and we will move on the next the next section to the next speaker is Puraha Pusahama from Thailand. He is the associate professor in Division of Cardiology, Department of Medical Medicine in Kongham University, Thailand. His topic will be the risk assessment in pulmonary hypertension group 1 and the risk guide treatment, monotherapy, initial combination or sequential combination drug therapy. So microphone to you, Dr. Brahama. Hello. I cannot see hear the voice of Dr.
I think the
Braha.
microphone is
yes.
off. Yeah.
Yes.
Okay, can you hear me?
Now
yes.
we can.
Okay.
Now we can.
And can you see the slide? Okay. So thank you, Chairperson, for your introductions, and thank you, the APAC, for having me for a privilege lecture today. It is my great honor to give a talk today. My talk today is about the risk assessment and the treatment of the pulmonary hypertension, or PIH. So this is my declaration of interests. I have nothing to declare with this talk. So the lecture outlines today is going to wrap up for the two important topics in PAH, which is including the risk assessment and the treatment of PAH, which is these two topics is mostly that we integrated together and talk together. So I will start with the, when we talk about the treatment strategies of the patient with PAH, as we know that PAH is the group 1 of PH, which include many categories inside this group 1. So before start treatment, I think we have to group the patient according to the required treatment strategy first. As my thought, I think in the PAH patient, I think we can group it into 3 classes. The first class is the patient with vasoreactive PAH, in which this patient should have a positive AVT and should start with the calcium channel blocker therapy, and some of them can respond well with calcium channel block in the long-term treatment. The second group, I think, is the largest group of PAH that, and we need to talk about it is a group we call the non-vasoreactive PAH, which include the idiopathic, the heritable, the drug-induced, and some of the connective tissue disease PAH, which is this group is the big group that we will talk today. And the third group is that I will call the other specific PAH. This is the SIV, this pulmonary hypertension, the congenital heart disease, which is the, I think in Thailand, it's the same as in Mongolia or other Asian country. This is the largest population of PAH. And also the PVOD is a minor population. This group, they actually, I think they need the PAH medication, but the strategy of the decision or escalation of therapy is different from the first two groups. So today, my talk will be focused on the first two groups only, for the vasoreactive and the non-vasoreactive classical PAH. I will start with the vasoreactive PAH first. I think this is, we have talked a lot of vasoreactive PAH, but in clinical practice, I have observed that we usually miss to do the test. I mean, the acute vasoreactivity test. Okay. We usually diagnose idiopathic PAH, but most of the patients never been before test the acute vasoreactivity. So for my talk today, I would like to encourage for the clinician or the cardiologist or anyone who perform the right heart cath for the patient. If you see the idiopathic, the drug-induced, or the like heritable PAH, you have to consider the AVT before classify and start the treatment for the patient. Right now, the guideline recommend the nitric oxide, the alloprost, and ibuprostenol as a recommended drug to do a test. So I think it could be feasible in many cath lab to do this. So please consider the AVT. And after we can diagnose vasoreactive PAH by this criteria. The first therapy should be calcium channel blocker monotherapy. It can be, but the important part is that we have to titrate the dose of the calcium channel blocker to a high dose. I mean, it's higher than the dose that we use to treat the systemic hypertension. This is one precaution. There are many calcium channel blocker available, and we can use. My experience, and I think many doctors have a good experience with nifedipine, but the others is good as well. For diltiazem or amlodipine, it is acceptable too. And from this latest update guideline, we suggest that the patient should be reassessed after 3 or 6 months of therapy, and we have to look if the patient can turn to a normal state or not, in which it must include the functional class assessment, the normal BNP, and also the near normal hemodynamics, which is important. We have to keep the patient, let's say the mean PAP below 30s and PVR below 4 root units. If we can achieve the target, then we can go with calcium channel block monotherapy. But if not, we have to shift the patient to the pathway of like the patient who are the negative responses. So I will go to the next group. It is the main group that we are going to talk today. It is a non-vasoreactive PAH, which is the concept of the treatment of this patient is that we have to treat them to target. This is the picture that is depicted over 10 years ago. We have to treat them to target. It means that we have to keep the patient stay at a very good functional capacity as most and as long as possible. Because if we let the patient drop from the optimal level of the functional capacity, if we let them stay drop it's very difficult for us to make them go up again. So the concept of the PAH therapy is that to keep the patient stay in the low risk categories as long and as most as possible. And to do so, we have to do it by give the PAH drug, give early and aggressively. Well, the 2015 guidelines have set the goal in the form of the risk assessment. in 2015 guidelines, I think we're familiar with this risk assessment. We have the clinical risk assessment. We have the functional capacity risk assessment. We have the biomarkers. We have the imaging. And definitely we have the hemodynamic that's absolutely needed. This is a picture of risk assessment. And after the publication in 2015, there are validations of this category. Is it good or not? Is it work or not? And there are three main publications that validate that risk stratification, which is divided into two validations. The first validation is that risk is good for diagnosis or for baseline prognostication. If we look at the data from the Swedish registry, from the French registry, and the computer registry, which is a large number of patients, the answer is yes. We can see that if the patient initially came at a low risk, the patient has a better survival. And in the opposite way, if the patient start at a higher risk, the patient's survival is worse. So the risk stratification is good at the first risk prognostication, but not also for the baseline prognostication. We want to prove at the follow-up prognostication too. Can we use it for the follow-up? We use the same risk category and we use the same data sets from the three main registry here. And we also see the same results in that. If we can keep or we can make a patient stay in the low risk profile or the low risk categories, the survival is better. So after the publication of the risk stratification, they have the validation and they confirm us is that we can use them both in the initial assessment and in the follow-up assessment, and they can lead up to help the patient to stay in the goal that we want. So when it comes to the latest guideline 2022, and there are some refinement of the risk assessment. The risk assessments have been separated into two groups. The first is that the initial risk evaluation, which is the 1, 2, 3 data, is a low risk, intermediate risk, and high risk. Is quite similar, and the parameter is look quite the same as the previous guideline, but there are some changes in the detail inside the table, which is for the use of initial risk evaluation. You can see that there are many parameters, and the guideline suggests that we should use as much as possible parameters because we need to clearly see where is the place that our patients stay in the risk category. And they also make a separation of the follow-up strategy evaluation, because in follow-up, you can understand that we cannot perform the sophisticated study in the follow-up clinic. So they pick up just a very strong risk prognostication, which is they are the functional class, the 6-minute walk distance, and the BNP or NT-proBNP, and they make it easily to like the score around the score. But you must observe that in the follow-up risk evaluation, they are the 4 strata. It's not the 3 strata. So there's some point different. So right now, the guideline advocate us to use the initial risk evaluation in like a full scheme of the risk, and the follow-up risk evaluation is like a easier risk strategy. And so to do so, I mean, to try to make a patient to stay in the low risk category, we have to find some new drugs or some treatment strategy, except other than monotherapy that we have like 10 more years ago. I will show you some publication that is the landmark publications for PAH and this impact for the new guideline update. You may have heard this many times before. This is a Seraphim trial of macitentan, which is in this trial, we compare the macitentan 2 doses, 3 milligrams and 10 milligrams with placebo in patient, in which some patients, they are the PAH naive therapy, and the endpoint is a clinical PAH worsening endpoint. And you can see that most of the patients are idiopathic, heritable, connective tissue, PAH, and also some patients are PAH naive. which is the result of the trial. This is the positive trial. The macitentan can show the positive benefit of the drug compared to placebo. So it's not only we can get the new drug, but we can also see that in terms of sequential combination therapy by macitentan on top of other medication, we can get a benefit. There also the evidence from the Griffon trial. This is a selexipag in PAH, which is the design is quite similar to the macitentan trial before. It is a comparison between selexipag and placebo. In PAH patient, maybe treatment with the ERA or PDE5 before, or maybe PAH naive treatment. We measure the clinical worsening PAH, and at the result, we can see that selexipag treatment is better than placebo, and even in any dose range, is still better. So we can get maybe this new drug for treatment and the new way, the evidence of the sequential combination therapy from this trial too. And also this is the one of the landmark trial, the important landmark, the ambition trial, which is the trial of the to compare the combination therapy of ambrisentan and tadalafil with monotherapy with either ambrisentan or tadalafil in PAH naive patient, and we measure the clinical worsening endpoint. And in this trial, we can see that initial combination therapy is better than the pooled monotherapy and better even with ambrisentan or even better than tadalafil monotherapy. So this is a landmark trial that proves that initial combination therapy should be the first strategy for the most of PAH case. There is also the COMPASS-2 trial, which is the sequential combination with bosentan on top of sildenafil in patient with PAH, in which we measure the clinical PAH worsening. And in this trial, unfortunately, we cannot see a positive sign of bosentan add-on sildenafil according to the clinical worsening PAH endpoint. But however, we still see that add-on bosentan therapy can make a patient feel better. They can walk longer, by 6-minute walk test is better. The functional capacity improve, but not the clinical worsening endpoint. So in the meta-analysis in 2016, comparing between combination therapy and monotherapy, we can see that combination therapy improve clinical worsening, but not all-cause mortality. So we still did not see the evidence that combination therapies improve all-cause mortality in PAH. After that, recently, we have two big important data. This is from the Triton study. This is the randomized trial between oral triple comparing with oral double therapy in PAH naive patients. This is macitentan plus tadalafil and selexipag. Unfortunately, the primary endpoint of PVR does not achieve, and also the 6-minute walk distance does not achieve too. But however, in the long-term follow-ups, it seems to be a positive signal of improved clinical worsening in the initial triple oral therapy. And there's also the data from the French PAH registry, which is we can see that the PAH patient who start treatment with initial triple combination therapy, including parenteral prostacyclins, they get a better survival than the patient who start with dual or monotherapy. So here I think we are going to the guidelines. The guidelines after both all evidence, the guideline have like suggest that for PAH patient, we divided two groups. The first group is that the patient without cardiopulmonary comorbidities, I would say the classical PAH. In this group, if the patient initially came in the low or intermediate risk, the guidelines suggest that we should start treatment with initial combination therapy orally with ERA or PDE5 inhibitors. But if the patient initially present in the high risk category, we should start with a triple combination and include the parenteral prostacyclin analog and follow up them and look again in what category they are. If they are in the low risk, okay, fine, they can stay in the same therapy. But if they are not in low risk, we have to do something else. If you stay in intermediate low, we can do like add the selexipag, prostacyclin receptor agonist, or switch from PDE5 to soluble guanylate cyclase stimulator. But if the patient are in the follow-up and are still in the high risk or intermediate high risk, it's unacceptable for us. We have to escalate therapy to triple combination with parenteral, prostacyclin analog, and listing for lung transplantation. And for patients with cardiopulmonary comorbidities, this is a non-classical PAH, which we see them a lot in the PH practice. They seem to be all with left heart phenotype, like a hypertension, AF, obesity, like that, or probably have some kind of lung disease. This is not a classical PAH, but they have a pre-capillary phenotype too. So because this group of patients is not did not enroll before the clinical trial, so the guidelines suggest that it should be just start with initial oral monotherapy, ERA or PDE5 inhibitor, either is okay. But if the patient is not okay with the first line monotherapy, so we can escalate combination therapy thereafter. So for this, I would conclude the strategy of the medication in this PAH patient. There are right now the 3 medication administration. The first is like the classical monotherapy strategy, which right now it seems to be only applicable in the patient who are PAH with cardiopulmonary comorbidities. The second strategy is that the combination therapy, but sequentially, in which you start the first drug, and then if the patient does not get better, you add another drug later on, which is also reserved for the patient with PAH who have the cardiopulmonary comorbidities. And the third strategy is that the combination therapy in the way of upfront or initial combination, in which you have to start maybe 2 or 3 drugs at the first time altogether, almost altogether, which is right now, it is the main recommendation for the PAH treatment. So I would go so quick right now because I think I'm going to run out of my time. This is, previously talk, but I would like to just write here that for the patient who are not better after the initial combination therapy, we can add selexipag in patient from the guideline. We can add selexipag who are in the intermediate to low risk, or we should add the parenteral prostacyclin if the patient are in intermediate high or high risk of therapy. And the choice of initial combination therapy, according to the evidence, it could be ambrisentan or tadalafil from ambition trial, or it could be macitentan or tadalafil from the Triton trial, or maybe either ERA or PD5 is okay, but oral macitentan, tadalafil, and selexipag is not recommended because it didn't work from the Triton trial. And importantly, that we have to avoid riosigod and PDE5 inhibitor because it could cause hypotension in patient. And for the patient with cardiopulmonary comorbidities, the guideline suggests that we should start with oral monotherapy, but we can add on sequential later. I would like to let you look at the list of the monotherapy that the guideline recommend. You can see that many of the drugs could be used as a monotherapy, but I think the appropriate one should be the ERA or PDE5 inhibitor as a monotherapy. But for the prostacyclin analog, it's maybe not quite easy to use as monotherapy in patients who are not at high risk. So I would like to conclude my talks today in the last slide. I would say like the first thing is in the treatment of PAH, we need to focus on the treat to target strategy. We have a target at the low risk, and we have to take our patient to that bar as low risk and as long as possible. And to do so, we have the risk assessment as our aim. But you know that the risk assessment is multi-parametric and is sophisticated to use, especially in the first risk assessment. So to do so, we have to choose this properly and wisely, according to the facility that we have in the clinics, and also depends on the individual patient status. And in treatment of PAH, I think we need to classify them clearly, whether or not they are vasoreactive, they are classical non-vasoreactive, or they are other PAH-specific type, because they require different approaches. And finally, in most cases of the classical PAH, I think the patients, finally, they need the PAH drug therapy. And right now, the initial combination therapy is being the first suggested strategies. So thank you very much for your attention.
Okay, thank you. A very nice talk, very concisely and very clearly. And it's open question for the audience and the panelists. First, to me, I think risk stratification and the treatment is very crucial and very important. The treatment and the question is the how to balance the drug cost and the ideally combination. So it's very struggle for us as also in Taiwan. The health insurance is not very well cover the initial combination and the sequential triple combination. So how about Thailand? Do the insurance fully recover for the so ideally treatment strategy?
Well, this question is very difficult to answer, and I think the status of each country, even in only one country, is different. Is different so much. In Thailand, I would say directly that we have 3 schemes of patients coverage, and there is one scheme that the patient has the most affordable coverage. So lucky enough, if the patient are in the one coverage, which is the patient can get maybe all of the drug that is the government pay for them. So it's fine for them. It's fine if they can get them for the initial combination therapy. But if not, if the patient stay in other scheme of therapy, this is a case-by-case decision, and this depends on the center too. I mean, but for my center, maybe the patient cannot afford the second drug, but we have some kind of extra fund. We set some extra budget, which is we can provide for some patient which we think that these patients they do require the combination therapy that we provided for them, but it's not happen in every center in my country.
Okay, thank you. I think it's very difficult question for especially for each country, because each country have a different insurance system and a different budget for the health industry. Yeah, and the second question is the you put a lot of emphasis in the vessel active test. I agree for that. But what is the percentage in your experience or in Thailand, the percentage of the vessel active pulmonary hypertension?
Okay.
Because in Taiwan, in our registry, we don't see a lot of vessel, less than 10% we have the vessel active pulmonary hypertension. So how about your experience?
Well, that's a good question too. I mean, according to the publication, it said that the patient with classical PAH, they seems to respond for the test not around 10%. And the patient who truly respond to calcium channel block in long term is lesser than that. I think this is the same in Thailand too, because in my experiences, there's just a few patients who have a positive response with calcium channel blocker. And for myself, I did not have patient who would respond only with calcium block monotherapy. But yeah. I mean, eventually after 2 or 3 months, they have to be added with other pH therapy. Even though in the cath lab, they show us that this case have a very dramatic response to the AVT in the cath lab.
Yes.
But finally, in the real treatment, in the long-term CCB, it doesn't seem so for the clinical responses.
Yeah, we also have some experience of, even we have a very great test in the vessel active test, but clinically they don't respond at the CCB at all. Yeah, so I don't know why, but yeah, but it still needs to worth to try initially treat CCB for these patients, but I don't think it's really reflect the real effect of the CCB. But just by using the vessel active tests. Yeah.
Yes, for me myself, I think waiting 3 or 6 months, as a guideline says, probably too long for CCB response. I think
especially in the high risk or intermediate risk patient. Yeah.
If they are going to respond, it seems to show us just within the month or 2. we can see them better. But if not, it seems like it's not about. Doesn't need to be through 6 months, I think.
Yeah, but the final question is, the last month we have a new drug, new player over sotatercept.
Yes.
So do you think it will change our practice or change our strategy?
Wow, interesting. We have been discussed with my colleague before, because after the publication of the trial, and there's have a lot of wave in the PAH society. I don't know. My answer should be, first is the price of the drug. It is the biggest barrier of the PAH therapy. I mean, in the Southeast Asian society, we have to look at the price first. If the price is not affordable, so I think there's quite a very tiny way for it to be listed for practical treatment.
Yeah, thank you. Dr. Mugan, do you have a question?
I don't have any question, and yeah, probably we
Okay,
proceed to the next speaker.
Yes.
Yes, thank you. So I would like to invite our next speaker, Dr. Kyung-hee Kim. She's from Korea. She's the research collaboration doctor at Mayo Clinic and director of heart transplantation in Sejong Hospital. So she will be speaking about treatment of pulmonary artery hypertension in adult congenital heart disease, surgical shunt correction, and or PH drug combination. So welcome, please.
Thank you for the introduction. Can you hear my voice?
Yes, it's clear.
Okay. I'll share my slide. Can you see my slide?
The slides are clear also. Thank you.
Okay. Thank you for giving me the opportunity to present lecture in this wonderful conference. I'm a cardiologist in Korea and work as heart transplantation director in our hospital. I'm really sorry there are some noises because I am talking in my hospital. I have nothing to disclose. Let me show you one of my patients who is 43 years old. She has never visited to the hospital, and chief complaint was palpitation and dyspnea. Her vital sign was blood pressure was normal. However, tachycardia and saturation was 80%. And CRP was elevated and proBNP was elevated up to over 2000. And ECG was tachycardia. And D-dimer was a normal range. And the echocardiography shows decreased RV function, but not dilated. And then there were no shunts. And at the first, PAP was very high. There was no murmur, and ultrasound shows no shunt. So of course, I suspected pulmonary embolism and filmed the CT first. We did the CT scan for distinguishing pulmonary embolism, and MDCT shows an enlargement of the pulmonary artery, an extensive intimal flap inside the proximal portion of the right interlobular pulmonary artery, and peripheral involvement of the common basal artery and the basal segment artery with partial thrombosis, and large PDA was detected. So on diagnosis of pulmonary artery dissection, the patient was transferred to ICU and stabilized vital sign. We treated like aortic dissection, BP under 100 and heart rate around 60. Since it was Eisenmenger disease by PDA and the result pulmonary artery dissection, blood pressure and pulse were controlled by using pH drug together. And the patient's condition became stable, but 1 week later, suddenly her heart rate was increased and cough was observed with fever. CRP was elevated and X-ray shows peripheral shadowing with changed antibiotics and continuing pH drug with tracleer and sildenafil. CT was retaken and eventually led to further development of pulmonary artery dissection and peripheral inflammatory response. And lung perfusion scan and defect on middle lobe and intensive medical care was priorly considered before further necessity of heart and lung transplantation. And I found there are some cases of PDA with Eisenmenger and pulmonary artery dissection. Only 2 cases were survived. So I did some heart failure medication and also pH drug. So after stabilization, her heart rate was around 60 and blood pressure was around 90. And there are some intimal flap and false lumen within the pulmonary artery. And after stabilization, we did catheterization. The cath was performed and the pulmonary artery resistance was very high, up to 33 wood unit. And when the vasoreactivity test was performed, it dropped to some extent, but it was 10 wood unit and more. And the only drug we decided to be used first, only pulmonary artery hypertension medication. So 1 week later, we continued the medication with pH drug, and 8 years later, she was stable with the medication. The medication was ambrisentan and sildenafil and selexpac, and also some heart failure medication with digoxin. And 6-minute walk test was increased up to 450 minutes. And saturation was around 90. But we could not close the PDA because the pulmonary vascular resistance still increased. And the echo follow-up shows the similar things, RV dilatation, but and then dysfunction. And then you can see some PDA flow, and then the pulmonary artery pressure was significantly decreased with the pH medication. However, we still could not close the PDA because the pulmonary vascular resistance was very high, and then she was very stable with the medication. And the CT scan, there are no other dissections of pulmonary artery. So there are some cases I already told you. The Eisenmenger syndrome with unrepaired PDA are rare. And then if there are some dissections, the fatality is really high. And so why? The first time we cannot hear the murmur was not heard in the patients was Eisenmenger syndrome by PDA. As a pulmonary vasculature disease progressed, the pressure difference between the great vessel folds progressively, and so does the intensity of the murmur. In patients with Eisenmenger syndrome, the shunt is bidirectional and mainly from right to left, low velocity and no associated murmur. In the presence of a high velocity shunt at PDA level at Eisenmenger patients, it may be difficult to diagnose the PDA on echocardiography. And so no one can answer whether it's right to close PDA patients with Eisenmenger. But there was a small study in 2020. 15 patients with PDA Eisenmenger were treated, and 4 patients with QPQS of over 1.5 or higher were treated with take a pH targeted drug for the first 6 months. The first failed after initiation of pH-targeted drug for 6 months in 4 patients. After the medication was adjusted and extended to 12 months, TCC was performed for all without hemodynamic intolerance during the perioperative period. Pulmonary artery systolic pressure was significantly decreased immediately after TCC. During a mean follow-up of 50 months, there were a further decrease of pH systolic pressure in 2 patients. The other 2 showed improved pulmonary vascular resistance and 6-minute walk test distance despite deteriorated pH systolic pressure. From this study, we can tell some selected PDA Eisenmenger syndrome patients might benefit from TCC, and combined pH-selected drug play a crucial role. We heard the previous lecture, pH is precapillary pulmonary hypertension, and patients with congenital heart disease enter here. This number accounts for a small number of all pulmonary hypertension patients and can perform pH-targeted therapy. Pulmonary hypertension refer to a mean PAP measured through right heart cath over 20 mm mercury and over, and pulmonary hypertension can occur in various clinical situations. And precapillary pulmonary hypertension, congenital heart disease is included in group 1, and pulmonary artery hypertension in PAP over 20 mm mercury and normal capillary wedge pressure and PVR over 2 Wood unit. Pulmonary artery hypertension in congenital heart disease, approximately 3 to 10% of congenital heart disease patients have pulmonary hypertension. It's more frequently encountered in female, and the incidence depends on the underlying lesion and increases with age and age defect clues. The estimated prevalence of pH in patients after correcting a simple cardiac defect is 3%, and the epidemiology of pH associated with adult congenital heart disease is expected to change due to advances in diagnosis and therapeutic pediatric cardiology, resulting in fewer patients with simple adult congenital heart disease and more patients with complex lesions and or a closed defect who develops pH in adulthood. And clinical classification of pulmonary artery hypertension associated with congenital heart disease is Eisenmenger, and pH associated with the systemic to pulmonary shunt. It could be some correctable or non-correctable if we treated with pH medication, and pH with a small defect. These patients with a clinical picture very similar to idiopathic pH, and pH with corrected cardiac surgery. pH in congenital heart disease, we can divide it pre versus post tricuspid valve. The vast variety of significant post-tricuspid shunt will develop pH if not repaired within the first few years of life, like PDA or VSD. However, if you treat it with the pH medication, you have a chance to close them. And most significant pre-tricuspid shunts will not. 5 to 10% of unrepaired ASD developed Eisenmenger syndrome. So classification of pH congenital heart disease, clinically, Eisenmenger and systemic to pulmonary shunts, and pH with coincidence small defect, and pH persistent or post-corrective surgery. and anatomical, pathophysiologically, and pre-tricuspid and post-tricuspid or complex. Nowadays, we can see some Eisenmenger syndromes with VSD. This is the patients with Eisenmenger with clubbing due to VSD. In the first time he developed a stroke and AFib, we can see the large VSD and then right heart failure and then sinuses. So we have no chance to treat him as pH-targeted therapy. And then besides the pH-targeted therapy, what other supportive measures we can do the patients with pH due to congenital heart disease is iron correction, anemia correction with iron, and regular dental care for prevention of infective endocarditis and avoid strength effort competitive sports, and oxygen therapy is little evidence. And management of arrhythmia and anticoagulation is some kind of debating. However, if the patient has arrhythmia, we should treatment with anticoagulation. And also some other comorbidities like hypertension and diabetes, we have to care about the comorbidities. So what is the evidence of the use of advanced therapies for pH in congenital heart disease? I'm just sorry. 발표 중인 건가? 어렵게 났어? 그러면 보호자를 빨리 불러요. 보호자를 빨리 불러서 그리고 내가 지금 발표 10분 내로 마칠게요. I'm really sorry. One of my patients is almost dying. I'm really sorry. So anyway, the pH in congenital heart disease and advanced therapies, data are still lacking on the optimal mode of following Eisenmenger patients in terms of assessing the need for starting therapies, their efficacy, and the need to up-titrated or escalated combination. There is a layer, the data is very rare. However, we can treat them as the pH therapies. And also, is pH same among PDA or VSD or ASD? And also, adult congenital heart disease patients, we should treat hypertension or heart failure medication. And then we have to consider some close the defect. Previously, there are less pH medication. There are still we have no chance to close the congenital heart disease with Eisenmenger syndrome. However, after some pH medication, we have some chance to close the congenital heart disease. And also, I would like to say, is the pH same among PDA and VSD or ASD? So ESC guideline shows like this: in patients with ASD, VSD, or PDA with pulmonary vascular resistance under 3-Wood unit, shunt close is recommended. And in patients with ASD, VSD, or PDA, a PVR around 3 to 5, shunt closure should be considered. And in patients with ASD, with the PVR over 5 that declines below 5 with pH treatment, shunt should be considered. And in patients with the VSD or PDA or PVR over 5, shunt close may be considered after careful evaluation in specialized century. However, in patients with ASD over PVR 5, despite pH treatment, shunt close is not recommended. So in the first time, AST or VST or PDA patients with the increased PVR patients, first pH medication is considered, and after that RV CAS, and then we can consider the close or not. So I will show you my patients, 45 years old female and then dyspnea. And you can see the pulmonary artery is engorged. And you can see the ECG was a sinus rhythm. And you can see the large VST, and then RV function was slightly decreased, and then RVH you can see. And then pulmonary hypertension by echocardiography was around 100. And then right case shows right pulmonary vascular resistance around 14, and mean PAP was over 70. And we did CT scanning, and then there are no pulmonary embolism. So she is a patient with Eisenmenger syndrome due to VST. So in the first time, we treated with bosentan and then increased the medication. And then after that, we combined with sildenafil. However, there was some paroxysmal arterial fibrillation. We need to add warfarin. So drug-drug interaction I considered. So I changed it to ambrisentan to sildenafil, and also some heart failure medication. And then right case again, but no change in hemodynamics. And then echo shows the like D shape and rise PDH, rise rise VST, and also pH systolic pressure around over 100. And then during the tonsillectomy, she has some chronic tonsillitis. VFib occurred and then fully recovered after defibrillation. So after we accepted the selexipag, I changed the medication, ambrisentan, selexipag, and warfarin, and aldactone, and digoxin. And 6-minute walk test was increased up to around 400 meters. And then the pH systolic pressure was significantly decreased eventually 5 years later. So, and so we did the CAS again. And then CAS shows right pulmonary vascular resistance was around 15. However, after vascular reactivity test, it was decreased up to 3.6. So we decided to partially close the VST. So VST closure with the fenestration and subaortic tissue resection. So as you can see, even though the VST was closed, you can see the D shape of the LV, and then the penetration, 7 millimeter penetration, and then now she doesn't feel any dyspnea, and then we keep the medication of pulmonary hypertension. So, and then, however, there are small evidences, the combination therapies of the pH targeted therapy in congenital heart disease. And then to close the defect, we have to risk assessment. And then risk assessment should be considered in patients with Eisenmenger syndrome. And also if the patients with the PAH, congenital heart disease patients, in women, pregnancy is not recommended. And also some vaccination and emotional support we should consider. So in summary, I would like to say the development of PH from congenital heart disease is common, and PH-specific therapies are getting more, but no evidence when escalating medications. However, in my cases, PH drug is, we should consider the in patients with highly pulmonary vascular resistance. And then after that, we need to test again, and then we can consider pulmonary, the defect clause. And also some supportive therapies like emotional therapy and correction anemia and stretching, etc. And also meticulous cardiac cath is really, really important. And then such patients are best treated in specialized center, combined congenital disease and PH center, and physiology and natural history differ differently to other types of PH. And also adult congenital disease, we should do some heart failure medication and also BP medication. And also we have to consider multi-center study. And in Korea, we have PH Korea this year, July 14 to 15. I hope you attend the conference. Thank you for your attention.
Thank you very much. It was very interesting cases and very precise presentation. So if our faculties have any questions, it's welcome. And are you in a rush to your patient, or is okay?
Yeah, I think I have to go. I'm really sorry.
Okay. So I think we are already over the time, so we can skip your Q&A session and we will probably move to the other speaker. So thank you very much. Thank you.
Thank you.
Thank you.
Thank you.
Professor Lin?
Yes. For the next speaker, because in the previous speech, we already learned about group 1 hypertension and pulmonary hypertension, and also due to the adult congenital heart disease. And later we will move to the group 4 pulmonary hypertension, which is also very important for the PH treatment, especially in the elder population. So the next speaker is Dr. Zhengwei Chen. Is from National Taiwan University Yunnan branch. He is the cardiologist and belong to the Department of Internal Medicine. And his topic is multimodal therapy in chronic thrombo-embolic pulmonary hypertension group 4, including the PH drug, pulmonary endarterectomy, and also balloon angioplasty. Microphone to you, Dr. Chen.
Okay, thanks for Dr. Lin. I will share my slide. Can anyone see my slide? Is that okay?
Yes, it's okay.
Okay, thank you. And good afternoon, everyone. I'm Dr. Chen Zhengwei from National Taiwan University. And it's my pleasure to be invited to give this talk. And my topic is the multimodal therapy in CTEPH patient. So this is my outline. So firstly, I should go from what is CTEPH. Before CTEPH, I should introduce CTEPH first. CTEPH is characterized as a symptomatic patient with evident pulmonary perfusion defects. And if combined with common hypertension, we will call it CTEPH. So according to the updated classification of pulmonary hypertension at this World Symposium, CTEPH is belong to group 4 pulmonary hypertension. So according to the 2022 ESC latest guideline for the treatment of pulmonary hypertension, the definition of pulmonary hypertension is mean PAP, pulmonary arterial pressure, more than 20 mmHg. So the epidemiology and prevalence of CTEPH, its prevalence is estimated about 8 to 40 cases per million. Also, the 2-year incidence after first-time pulmonary embolism was 3.8%, and around 30% of CTEPH patients also have never had pulmonary embolism. In 2025, the estimated CTEPH patient is more than 75,000. So we could see the cumulative incidence of symptomatic CTEPH after pulmonary embolism increased up to 3.8% at 2 years and can be as long as 10 years. As a result, in the patients with persistent or new onset dyspnea following pulmonary embolism, further evaluation to access the CTEPH is class 1 recommendation. As to the clinical manifestation of CTEPH, the symptoms of CTEPH are indistinguishable from other forms of pulmonary hypertension and many other respiratory and cardiac disease. And the common symptoms are related to the stages and severity of the disease. As to a risk factor of CTEPH, the previous pulmonary embolism is the most important factor, and others include the younger age or large perfusion defects, idiopathic pulmonary embolism at presentation. As we could see from the picture, CTEPH is very different to the pulmonary embolism. The pathology in CTEPH show the organized thrombi, fibrosis, internal hyperplasia, and recanalized channel. This is the traditional model of CTEPH progression. Following pulmonary embolism, incomplete thrombus resolution, formation of thrombosis, fibrosis, and remodeling of the pulmonary blood vessels will cause increased pulmonary vascular resistance, and it will cause the progression of pulmonary hypertension and eventually right heart failure. So how can we diagnose this CTEPH? When CTEPH was suspected, the perfusion scan and echocardiography could be arranged to rule in the diagnosis. The further CT pulmonary angiography and right heart catheterization will be performed to confirm the diagnosis. So how do we treat the CTEPH in multimodality approaches? The treatment of CTEPH depends on the sizes of vessel, including PEA, BPA, and medical treatment, and I will discuss separately in the following section. From the 2022 ESC guideline, when CTEPH was suspected and was confirmed, the lifelong anticoagulant should be given. And after assessing by the multidisciplinary team, the PEA is the treatment of choice if indicated. If patient suffer from persistent or recurrent symptomatic pulmonary hypertension, medical therapy and BPA were indicated. Besides, BPA may be considered for technically operable patient if unfavorable risk and benefits ratio. Here is our CTEPH group in National Taiwan University Hospital, and we photographed it with Professor Hopper. So let's start from the surgical treatment. Surgical treatment is a pulmonary endarterectomy, and we will also call the PEA. PEA is the only curative treatment for CTEPH. In PEA, the scar tissue is carefully removed from the pulmonary artery. So how can we evaluate the operability? The pulmonary angiography is the gold standard and procedure for the evaluation of operability. It included anatomical picture of pulmonary artery and dynamic picture of small artery and capillary blood flow to evaluate the operability of CTEPH patient. Here is our National Taiwan University experiences. As we could see, after PEA, improved the NYHA classification, increased this mean walking distance, and decreased BNP, NT-proBNP, decreased TRPG, and increased left ventricular ejection fraction were found. So from the 2022 ESC guideline, we could see the PA remained the class 1 indication treatment of choice in CTEPH patient if accessible is indicated for surgery. And other, we could see the PA or BPA should also be considered in selected symptomatic patient with CTEPH without pulmonary hypertension. And this is the class 2A recommendation. According to the previous study, we could see the non-operable CTEPH accounted for around 20 to 40% of patients. The most common reason is distal or inaccessible thromboembolism is around half of the CTEPH patient. Although some selection bias may exist, it seems that in CTEPH patient receiving PA have better survival outcome and more freedom from the clinical worsening than in operable patient. So let's move to the medical treatment of CTEPH. First, the lifelong anticoagulation are recommended in all CTEPH patients, and the anticoagulant may reduce the risk of a recurrent thromboembolism. However, in CTEPH with APS, we should notice that antiphospholipid syndrome testing is recommended in CTEPH patient. And also, if it is diagnosed, the VKA is recommended for the treatment. As to the medication for CTEPH, riociguat remain the only FDA-approved medication for CTEPH. Besides CTEPH, there are also some like subcutaneous treprostinil, and other combination therapy may be considered in inoperable CTEPH patient, but this is the class 2B recommendation. For the mechanism of riociguat, riociguat have the dual mode of action, including the sensitizing the soluble granulocyclase to endogenous NO by stabilizing its binding, and also it's directly stimulating soluble granulocyclase independently of NO. The approval of riociguat was based on CHEST-1 and CHEST-2 trial. The CHEST-1 trial is a multi-center study to compare the outcome between riociguat and placebo. As we could see, the results show significantly increased the 6-minute walking distance in riociguat group. And the CHEST-2 study is a long-term open-label follow-up study of CHEST-1. It also showed a sustained improvement of 6-minute walking distance in riociguat group. Besides 6-minute walking distance, other hemodynamic parameters, including PVR, PAP, cardiac output, and NT-proBNP also show significant improvement. In our hospital's experience, we also showed a significant improvement in this parameter. Besides, the magnitude of the improvement is similar to the CHEST-1 study. So let's move on the last section. How about the endovascular treatment of CTEPH? Although the PA remain the golden standards, there are some unmet need for this in operable patients. BPA, so-called balloon pulmonary angioplasty, are the alternative treatments. And the first case was reported by Woodbridge in 1988. Follow up the case series reported by Finstein in 2001. At that time, BPA had very high complication rates, including in their report, 70% of patients required mechanical ventilation, and 61% of patients developed pulmonary edema. So, due to less high complication, some refining technique developed to decrease the complication rates, including splitting the treatment course to 3 to 5 sections, and with 1 to 2 pulmonary segments per section. Also, sometimes IVUS was also applied to determine the optimal balloon sizing. Before BPA, we should notice that there are some important points we should keep in mind. Like we could lower the mean PAP first to decrease the BPA complication. And also we could apply the VQ scan to identify the mismatched region. And the BPA procedure, I should remind first that it requires the good quality of pulmonary angiography and the selected segmental angiography. So let's see what the latest ESC guidelines said. In CTEPH patients who are candidates for BPA, medical therapy should be considered prior to BPA. And this point come from the RED study. The RED study, the trial design was as followed. As we could see, the inoperable CTEPH patients were enrolled and received riociguat and BPA separately. After primary endpoints at week 26, The BPA was added to riociguat, and riociguat were added to the BPA. The primary endpoint at 26 weeks show that the BPA group has significantly lower PVR, NT-proBNP, and both dyspnea score and WHO functional class improvement. But BPA shows significantly higher treatment-related adverse events. And the extended study at week 52, the PVR decreased was similar between two groups. However, in the safety assessment, the first-line BPA had more severe BPA-related complication than first-line riociguat group. In another study, it's called MRBPA. It's just published in the same journal, Lancet Respiratory Medicine, and it is conducted in Japan. It compared the treatment effect of BPA and riociguat in inoperable CTEPH patients. And we could see the results show that the BPA was associated with a greater improvement. Here is the illustration for the BPA procedure. We just find the target lesion. When applied, the balloon to dilate the lesion, and the pulmonary blood flow restored. The lesion in CTEPH is totally different from the lesion we seen in the PCI. The lesion morphology included like webs, slits, and web and slits is combination, or others like complete obstruction or narrowing without distal runoff. This is the pathological view of webs and slits. We could also see the 3D OCT demonstrates the web morphology. After BPA, we could see the hemodynamic parameter, including the PAP, cardiac output, and pulmonary vascular resistance all improved significantly, and the 30-day mortality decreased after in a recent year. Others like WHO functional class, 6-minute working distance, and BNP level also improved a lot. And the echocardiography parameter also show significantly improvement. In our hospital, we also showed the improvement of this parameter, and it also showed a very good efficacy. However, we should watch out the BPA complication, including the vascular injury, even with or without hemoptysis, and the lung injury, including the reperfusion, lung edema, and even respiratory failure. In our experience in our cohort, in total 59 BPA section and total 189 pulmonary segments, 2 episodes of pulmonary vessel extravasation, 4 episodes of hemoptysis, and 3 episodes of reperfusion pulmonary edema were noticed. Here are some chest X-ray examples show the reperfusion pulmonary edema after BPA with different severity. Pulmonary edema predicting scoring index named as the PEPC, defined by the change of the pulmonary blood flow grade scores multiplied by baseline PVR, can be applied to predict the risk of the reperfusion pulmonary edema, and others like risk factors like first section, high mean PAP, high PVR, and BNP level. So how can we see the change in the guideline? In 2015 ESC guideline, the BPA remained the class 2B indication. But now in the 2022 latest ESC guideline, we could find that the BPA was escalated to the class 1 recommendation in inoperable CTEPH patient or a residual pulmonary hypertension after PEA. So let's to conclude. If the CTEPH is confirmed, and we could see if patient if the CTEPH is operable, the PA pulmonary endarterectomy is indicated. If it is non-operable and the BPA is not possible, the medication therapy should be given. And if BPA possible, we should give BPA or BPA combined with medication And according to a rat study, maybe we could give the medication first to lower the mean PAP and followed by the BPA, maybe may have the less BPA complication. And if it had a mixed type, maybe we could give the PA with BPA combination therapy for the patient. Oh, so this is thanks for your attention, and this is my presentation for the multimodality therapy in CTEPH patient. Thank you.
Okay, thank you for your very concise and a clear speech. Because of a time limit, and we have a lot of a lack of the time, so we will keep your question to the next the last Q&A section. So
Okay.
let's move to the last session of the speech. Please, Dr. Mugen.
Yeah, thank you very much. So next we would like to invite Dr. Masaru Hatano from Japan. He's the associate professor from the Department of Advanced Medical Center for Heart Failure, University of Tokyo. He will be speaking about lung transplantation in progressive unresponsive pulmonary artery hypertension, group 1, and pulmonary hypertension associated with lung diseases or chronic thromboembolism, criteria, listing, and therapeutic experience. Please welcome Dr.
I'm Masaru Hatano from Tokyo University. I'm now in airport line, so I cannot speak loud. So please share this my previous recorded slide, please. Thank you, chairs and ladies and gentlemen. I'm Masaru Hatano from Tokyo University. It is a great honor for me to make a presentation at this APSC Cloud webinar. Today, I will talk about lung transplantation in patients with pulmonary hypertension. This slide shows updated clinical classification of pulmonary hypertension from 2022 ESC and ERS guidelines. At first, I would like to talk about Group 4 PH CTEPH. As you know, CTEPH was a disease with a poor prognosis until the early 2000s. Pulmonary endarterectomy has been performed for central type of CTEPH since 1990s. On the other hand, lung transplantation was required for patients who were not eligible for PEA. According to Bonderman, of 181 CTEPH patients between 1999 to 2006, 105 patients underwent PEA, and the remaining 76 did not. 8 patients underwent lung transplantation, but the 3-year survival rate was only about 80%, even in patients without an associated medical condition with a relatively good prognosis. However, from 15 years ago, BPA became widely used around the world, mainly in Japan. The number of BPA is increasing year by year. We performed about 500 sessions of BPA to 83 patients with CTEPH in Tokyo University. Hemodynamic parameters dramatically improved, and pulmonary artery pressure became almost normal after BPA. The in-hospital mortality for BPA is only 0.2%, and its long-term prognosis is quite excellent. This slide shows the long-term outcome of CTEPH from a Japanese prospective cohort. This study compared warfarin with drugs, and both groups had an excellent prognosis, with a 3-year survival rate of over 95%. Of course, no one needed a lung transplantation. CTEPH is no longer a disease that requires a lung transplantation. Next, I would like to talk about lung transplantation for pulmonary artery hypertension, which is the main theme of today. This slide shows the latest treatment algorithm for PAH. As is shown in this slide, lung transplantation is considered for refractory cases using continuous intravenous or subcutaneous prostacyclin analogs. Risk stratification is performed at the time of treatment strategy consideration, and the risk classification at the start of treatment is performed using 3 strata models, and treatment response evaluation is performed using 4 strata models. This slide shows risk classification by 3 strata model. It is a detailed classification consisting of a total of 10 parameters: symptoms, exercise capacity, plasma BNP or NT-proBNP level, echocardiographic findings, cardiac MRI, and right heart catheterization. On the other hand, the 4-strata model risk classification consists of only 4 parameters, which is very simple and can be evaluated repeatedly. The current ESC and ERS guidelines recommended potentially eligible candidates are referred for lung transplantation evaluation when they have an inadequate response to oral combination therapy, indicated by intermediate, high, or high risk, and recommend to list a patient for lung transplantation who present with a high risk of death despite receiving optimized medical therapy, including subcutaneous or intravenous prostacyclin analogs. However, high-risk patients in the 4-strata risk assessment model are quite severe cases that satisfy 2 or more of the following 3 criteria: WHO functional class 4, 6 minutes walk distance below 165 meters, and BNP more than 800. In order to reach the goal for these patients, it is necessary to have an environment in which transplantation can be received early after listing. As a practical matter, the environment surrounding transplantation greatly differs from region to region. In European countries, with a population of about 500 million, more than 2,000 patients can receive lung transplantation per year. However, the organization situation in Asia is very different from that in Europe and the United States. The United States has the highest number of donors per million population at more than 38. But the number of Asian countries is low, with South Korea having the largest number at 8.68 and Japan at only 0.99. In the United States, where the number of transplants is high, a system called the lung allocation score, which scores underlying disease, exercise capacity, laboratory finding, and so on, has been established. This system ensures that patients with greater need are prioritized for lung transplantation. In fact, the introduction of lung allocation score markedly reduced waiting mortality in patients undergoing both lung and heart-lung transplantation for patients with IPH. Although there was no significant difference in the prognosis after heart-lung transplantation, the prognosis after lung transplantation was significantly improved after the introduction of lung allocation score. As for the actual situation of transplantation in Japan, only 3 cases of heart-lung transplantation have been carried out, and living lung transplantation is still being carried out at present due to a serious shortage of brain-dead donors. On the other hand, the prognosis after lung transplantation is good, with a 5-year survival rate of about 75% for both living donor and brain-dead transplants. However, the number of transplantation is extremely small. In European countries, with a population of 500 million, more than 2,000 lung transplantations are performed per year, whereas the number of lung transplantations has remained below 100 per year in Japan. The situation is the same at the University of Tokyo, which is one of the largest lung transplant facilities in Japan, and the number of listed patients continues to exceed the number of transplantation. As a result, the number of patients waiting for lung transplantation at the University of Tokyo now exceeds 120, and the waiting period is expected to be more than 3 years. The current criteria for lung transplantation waiting list registration in Japan adopt the 2015 ISHLT guidelines. However, as with the 2022 ESC and ERS guidelines, considering the extremely long waiting period for transplantation in Japan, it would be too late to enroll if this criterion was fulfilled. Therefore, we examined the patients who were referred for lung transplantation at our hospital in order to the appropriate timing for lung transplant waiting list registration in Japan. From May 2014 to December 2021, of the 59 patients who were referred for lung transplantation at our hospital, excluding patients with insufficient data or right to left shunt, 52 patients' backgrounds were reviewed. The left panel shows the risk classification of patients using the 3-strat model, and the right panel shows the classification using the 4-strat model. In both classifications, only a very small number of people are classified as a high risk, and although there is no doubt that these patients need transplantation, it seems too late to list them after they became high risk. This slide shows survival analysis of the cohort stratified 3-strat model, 4-strat model, and modified risk assessment. As you see in this slide, modified risk assessment clearly defined the poor prognosis group. 3-year survival rate was about 80% in low intermediate group. On the other hand, 3-year survival rate of high intermediate group was about only 30%. In fact, multivariate Cox proportional analysis revealed that intermediate high or high risk in modified risk stratification was an independent prognostic factor after referral for lung transplantation. We think patients with intermediate high risk in modified risk assessment should be listed for lung transplantation. Finally, I would like to talk a little bit about Group 3 PH. This slide shows the prognosis of SSC-PAH and ILD-PH. ILD-PH has a worse prognosis than SSC-PAH, and the presence of ILD itself a much stronger prognostic factor than pulmonary vascular resistance. As you can see from the previous slide, Group 3 PH has a particularly poor prognosis, and how to survive the waiting period for transplantation is a major issue. This slide shows the result of using ECMO in Group 3 PH patient awaiting lung transplantation. The left panel shows that VA ECMO had a better prognosis than VV ECMO, and more patients reached transplantation. In addition, the right panel shows that conversion of VV ECMO to VA ECMO improved prognosis. However, even if VA ECMO is used, the 50-day survival rate is less than 50%, and it is considered difficult to become a realistic solution in countries with long waiting periods for transplantation. Here, I'd like to introduce two surgical procedures for patients with severe PH waiting lung transplantation. One is reversed port shunt. This is left pulmonary artery to descending aortic shunt with one nail valve. Rosenweg et al. Reported that result of reversed port shunt for 5 patients with severe PAH. Their hemodynamic parameters are severely impaired before procedure. Their average mean pulmonary artery pressure was 92 mmHg. Although oxygenation deteriorated after procedure, no procedure-related deaths, and all patients survived without lung transplantation during observation period. The other is Novalung. Novalung is pumpless oxygenating right to left shunt between the pulmonary artery and right atrium. Lower panel shows the result of Novalung for 4 patients. There is a patient undergo lung transplantation after up to 69 days support. Neither procedure has been performed in Japan yet. It is hoped that device or procedures that can withstand long waiting period will be developed. In conclusion, with the widespread use of BPA, CTEPH is no longer a disease requiring lung transplantation. Despite dramatic advances in drug therapy for PAH, there are still many PAH patients who require lung transplantation. Although the prognosis after lung transplantation is excellent in Japan, the major problem is the serious shortage of donors and the long waiting period. It is necessary to consider when to register patients with pulmonary hypertension as waiting list for transplantation according to the circumstances of transplantation in each country. Group 3 PH has a particularly poor prognosis, and how to manage the period until transplantation is an issue for future study. Thank you for your attention.
Thank you very much, Professor Masaru Hatano. It was very interesting for me to hear this presentation because actually in Mongolia we have much less experience in terms of the transplantation, and the presentation was quite interesting to me. How about our faculties? Do you have any questions to Professor Masaru?
Yes, very interesting and a very nice experience for the lung transplantation. as you present, right now the data of the lung transplantation and heart lung transplantation is similar, but sometimes we still see the pulmonary hypertension patient with right heart failure is needed the heart lung transplantation. So when to choose heart lung transplantation and when to choose the single lung transplantation, is there easy or the scoring system or parameter to choose either one?
Do you mean double lung or single lung?
No, lung or heart lung.
Heart lung. Oh, yeah. Okay. I know. So severely ill patient need to heart lung transplantation, but because of shortage, severe donor shortage of Japan, so almost all patients are listed for double lung transplantation, not heart lung transplantation. We have only 3 patients performed heart lung transplantation in Japan for more than 20 years. So complicated simple such as ASD or VSD. So such patients with Eisenmenger syndrome, received lung transplantation and had only lung transplantation. So this is because of the severe shortage of donor in Japan.
Okay, thank you. But in very severe right heart failure patients, if you only do the lung transplantation, sometimes it still get a very, very poor heart function. So,
yep.
So in our hospital, we will consider heart lung transplantation according to the right heart cath. If the cardiac output is very, very low, and we will consider about heart lung transplantation. But it still depends on the expert opinion, and there is no very easy parameter to according to. So I think it's still very hard, very critical issue for that. And another question is for the VAD, ventricular assistance device. Do you think there is a role for the very extreme pulmonary hypertension with right heart failure patient, but it's not candidate for the lung transplantation? Do you think it's helpful for the RVAD?
I think it is difficult for to manage to add bed for a long time. So it is not realistic. So I recommend central ECMO. You know. Central ECMO can used long term. My experience, longest time support period by central ECMO more than half a year.
Oh, really good.
Yeah.
Experience. Because we also use the central ECMO for the severe pulmonary hypertension, but the data is not so good. Yeah. So sometimes we will think to shift to the long-term device, and the LVAD is very good for the systolic heart failure. So we think maybe probably the RVAD still works, but we don't know. We don't know. Yeah. And the question for another speaker, Dr. Chen, because you have to point out the data of the REST study, probably the when the pulmonary pressure is high in CTEPH patient, you can use the drug first. And in the Japan study, the MRPBA study, they don't use the drug first. So what do you think? Which kind of patient we have to use the medication first, or is no difference? If your procedure skill is very good, you can just do the PBA first.
Thanks for Dr. Lin's question. This is very important, and I think the firstly, this two trial is quite different because the trial in Japan, they just compare the BPA and the riociguat, but in the rat study, they have the very spatial designs. They just add the riociguat to the BPA group and the BPA to a riociguat group to compare which first. But in Japan study, they can answer this question. So this is the first point. And in the second point, I want to say that which patient should receive the medication first. I think now, at least now, no any trial can give the definite answer. But in my opinion, I think that if you feel it's a PAP is very high, like very severe pulmonary hypertension, maybe we can just add the riociguat maybe 3 to 6 months to lower their PAP first, and also we could see that some patient even can the symptom very severe, so we can just use the medication to soften their symptom and just let them more comfort to receive the BPA. I think it's more good practice. But as your question, what kind of patient or the cut points of mean PAP or cut points of PVR should we use medication for? I think until now we have no definite answer. Thank you.
Yeah,
So
I think the
may I have
concept.
some thoughts
Yeah.
about the PAH therapy in BPA?
Pardon?
I would like to share my thought about the PAH drug on BPA.
Sure, please.
Yeah.
Sure.
Okay. I perform BPA also here in Khon Kaen in Thailand. So, and in my personal idea, I think because of the PH drug, we can have in my situation, we can afford the PDE5 inhibitor with a affordable cost. It's not so expensive, and you can say that in the patient with not very high PA pressure, the risk of the lung injury is not high. Yes, it's correct. But if it occurs during the procedure, it could make some troubles. So for my thought, I would say the PH drug is okay. We can give at least monotherapy. The price is affordable, and the risk of the drug is not high. So for me, if the patient have a considerably high mean PAP, let's say above 30, I would consider empiric therapy with PD5. Unluckily, we don't have the riociguat in Thailand available. So I will start the PD5 meter in about 2 or 3 months later, and then we schedule for BPA.
So do you use the PDE5 inhibitor in CTEPH patient, or you use the riociguat?
I use PD5 inhibitors. We don't have riociguat in Thailand. It's not available here.
Oh, really? Oh, wow.
Yes, but it's fine.
It's fine. Okay, I see. Yeah, but I think in the ERS guideline, ESC guideline, they say in the CTEPH patient, if you have a high pulmonary resistance or pulmonary high pressure, recommendation is you use the medication first and then the PBA. But if the pressure is low, I think it depends on the doctor or operator. I think either one is okay. Yeah, just make you and the patient comfortable is okay. Yes, and also I think the pre-operation medication is also interesting in the CTEPH patient for operation, because in our for the surgeon, we don't have to use medication first before the PEA endarterectomy. Yeah, because they say the drug will make the tissue difficult to operate, so they don't like to use the PAH medication first. But according to the REST study, if we give some patient the medication first before we do the BPA is better. I was just wondering if we do the PEA before the procedure, we use the Real-Sigma first 2 or 3 months. It will be better for the perioperative risk prevention. But I think this the question can I ask Dr. Hatano, because maybe you are only the surgeon in the leading this webcast.
I think some surgeons prefer introduction of Real-Sigma before PEA, but it depends on the surgeon. So in a severe case, PEA or BPA before PEA or BPA, so severely reduce the cardiac output. So cases. I recommend Real-Sigma so before PA or BPA, because Real-Sigma is much more power so to increase the cardiac outputs. So I recommend for severe cases reduce cardiac output severely decreased.
Yeah. I remember there is a study, randomized study, to compare the preoperative Real-Sigma and the placebo for the operation, for the PE operation, but I still don't know the result. It's already maybe 4 or 5 years. I don't know what happened for the trial. Yeah, so for the other faculty, is there any problem for the speakers? Okay, is Dr. King? Dr. King is still here? Oh no, I don't think so.
I think she's not here.
Patient.
Yeah.
Okay. So maybe we have already.
I have just one last question.
Yeah. Yes, sure.
Just I would like to ask about the taste for the screening or diagnosis of CTEPH in your practice, because the guideline recommend the VQ scanning as a first screening tool for CTEPH. But
yes,
this is a lot of questions because of some centers do not have this test in their own centers, and others might be familiar with other kind like a CTPA rather than VQ scan. So I just would like to ask about your thought according to the screening tool or diagnosis of CTEPH.
Yeah, I think I speak first because I also do the CTEPH mainly in my practical many practice. But I think the problem of the CTPA is the sensitivity, because in the very distal type disease, you cannot, probably because of the artifact or many issue, you cannot detect the very distal disease. And the sensitivity specificity is questionable for the very distal disease. So, but for the maybe majority of the disease, the patients is okay. And also, if you don't have the VQ scan, we sometimes we are trying to do some special CT for the recommendation that some CT had a perfusion, like the perfusion the function. We can estimate the perfusion. Yeah, so probably you can also ask your colleague in radiology, do they have also the perfusion function of the CT? Yeah, CT angiography. Yeah, but I think still we still do the VQ scan as the first screen tool. I think it's because it's very sensitive, but because it's too sensitive, so sometimes we have still we will see there is a positive VQ scan, but it's not CTEPH. Yeah, it has a very high sensitivity, but the specificity, especially in some small multiple non-segmental perfusion defect, is sometimes usual for the other type of pulmonary hypertension. Yeah, so you have to very carefully interpret the result of the perfusion scan. Yeah, so there from the Mongolia or the Japan, do you want to share your experience for the CTEPH detection by the VQ scan?
In terms of from Mongolia, actually, we are having quite difficulty in terms of diagnosing pulmonary arterial hypertension, even including the diagnostic tool availability and its prices. So whenever pulmonary arterial hypertension patient comes, our first evaluation technique will be echo, and that's almost something that we can do, and further it's quite difficult. And even for the medications, it's quite difficult because not many medications are available in Mongolia. For example, we do have sildenafil, but other options are quite absent. So it's becoming quite challenging problem for us to manage pulmonary arterial hypertension patients. But I hope we can progress further. Yeah. Thank you.
Dr. Hatano, do you want to share your experience over the screen?
In Japan, the dual energy CT is available, so many patient institutes. So of course, the VQ scan is very good. So, but I think dual energy CT is growing much more used in Japan, I think.
Yeah, I think dual energy CT is good. Yeah, and but we don't still have many data about the dual energy CT and compared to the VQ scan. But in our experience, the result of dual energy CT between dual energy CT and the VQ scan are quite very similar. It's very identical when you just compare the two. Yeah.
Dual energy CT is useful for treatment target vessel to detect determine the target vessel. So it is very effective, I think.
Yeah. But VQ scan, we have the perfusion scan. We also have the SPEC CT for perfusion scan. Yeah. So it also very useful for that. Yeah. We are currently do the study compare dual energy CT and the VQ scan. Okay, I think the time is up, and I have 2 minutes for the closing remark. And I'm very happy to talk with so many experts and the lecture person. And we have the 5 topics here. The first, we have the Dr. Yang Sun Yuan for the update diagnosis and the classification for the pulmonary hypertension. Then we have Dr. Pusahama for the risk stratification and the combination or the monotherapy for the how to treat the patients. I think is very important, but I think it's very depend on the insurance recover. Yeah, the coverage of insurance. And then we have the Dr. King for the treatment of very special entity of the disease, the adult congenital heart disease. I think it's still very difficult to approach, and it's still very much work we can handle that. And then we have the Dr. Chen for the treatment of the CTEPH patient for the diagnosis and the treatment, including the multi-model, including the medication, surgery, and angioplasty. I think right now the group 4 pulmonary hypertension is the best outcome patient for all the PAH entity. And the last we have the Dr. Hatano. They talk about the lung transplantation current strategy and the current the development of the lung transplantation for the group 1, group 3, and the group 4 patients. And we know the group 4 PH patients, we already no need for the lung transplantation, but we still have to work, and we have to do the pulmonary the group 1 and the group 3 pulmonary hypertension. So and the last, I want to have a great thank for the organizing committee of APSC Cloud webinar, especially Professor Junyi Lin, for organizing such a good committee for us to talk about the current treatment of the pulmonary hypertension. And I think that this will help the member of the APSC for dealing and the treatment their patient very much. Thank you.
Thank you. Thank you all. Thank you for all your contribution. Thank you.
Yeah, thank you
Okay.
for
Thank you all the
the
speakers. Thank you.
yeah.
Thank you.
Thank you.
Thank you.
And I'll see you next time.
Okay. So see you. Goodbye,
See you.
everyone.
Bye.
Okay. Goodbye.
Bye.
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 Bye bye.
Bye. Bye.